All right, so today, the purpose of today is to discuss the proposed regulation on nurse staffing ratios for ICUs. And depending on the discussion, I just want to set this up for the committee. The discussion will be to review these draft regulations, proposed regulations, and then if we concur, we would move them to the full commission meeting, which would be on the later this month, to put them forward to public hearing. So this is not for us to approve final regulations, it's to move the process to the full commission to then put it to public comment. So with that, I thought I'd turn it over to Lois. You're going to walk us through these regulations?
Yes.
These proposed draft regulations considerations?
Yes, thank you. Good morning, everybody.
So all of the committee members should have received copies of the draft proposed regulation.
Okay, good. And to frame our discussion today, I'm going to first review the key statutory requirements, highlight some of the considerations that we've had in developing the regulation, provide an overview, and finally discuss next steps in our regulatory process. So first, starting with the statutory language that we've discussed previously, as you see on slide 6, the law requires that patient assignments in all ICUs shall be a registered nurse to patient ratio of 1:1 or 1:2, depending on the stability of the patient as assessed by the acuity tool and by the staff nurses in the unit, and the nurse manager or designee when needed to resolve a disagreement. As you know, the Health Policy Commission is required to develop regulations to implement this law, including on the formulation of the acuity tool, public reporting of staff and compliance, as well as public reporting of identified quality measures. To develop our regulations, since the law was passed last summer, we have prioritized stakeholder engagement and opportunities to learn both from hospitals and nurses as well as the general public. We've held 2 listening sessions, visited a number of ICUs, discussed the regulations at several committee meetings, and had numerous meetings with hospitals, nurses, experts, as shown on this slide, and a number of parties have provided input. And as reviewed with this committee in December, our research showed that acuity tools are not widely used in Massachusetts hospitals, more so among academic medical centers and community hospitals. And even where they are used, they are typically used for core staff planning or budget reasons, rather than to make staff assignments prospectively as called for by the statute. The types of tools that are used vary. They range from paper checklists to more sophisticated electronic software applications, and they range from proprietary to custom developed for a particular hospital's ICU, and there are several models in between that. We have looked to other states, and our statute is unique in requiring the use of an acuity tool. We looked to California as a model, as they have mandated staff ratios. And other states require staffing plans, but certainly in developing these regulations, we have to some extent broken ground as we confronted for the first time a lot of complex issues. Just some key considerations to keep in mind as we discuss the proposed regulation today. First, as Commissioner Sutters noted, this is the very beginning of a regulatory process, which in addition to the public input that we received to date, builds in a required public comment period and a public hearing. And we look forward, of course, to continued engagement not only with the committee and the full commission, but with stakeholders, agencies, as we move forward to refine the regulation. Second, given the extensive and often divergent input that we have received and the complexity of these issues, the proposed regulation that you have before you today really strives to strike an appropriate balance, providing sufficient guidance consistent with the statutory purpose of promoting patient-centered staffing, while at the same time recognizing the unique circumstances of each hospital and each ICU. And as you we'll see as we walk through the regulation, we did that in large part through a strong emphasis on process requirements in the development and selection of the acuity tool. Third consideration is that consistent with much of the testimony that we've received to date, the regulation also places an emphasis on the role of the staff nurse, especially as it requires that staff nurses have a meaningful opportunity to provide input in the selection and development of the acuity tool and how it will be implemented in the ICU. Finally, as we develop the regulation, we're mindful that the Department of Public Health, or DPH, will be certifying the tools and will need to develop certification and enforcement processes. But our regulation does include certain documentation and reporting requirements to enable DPH to carry out these roles. So with these considerations in mind, I will now turn to provide an overview of the regulations you see here. Here's the table of contents of the variety of sections. The next slide shows some key definitions, and I'm just going to highlight just a few of the definitions. In developing these definitions, we incorporated terms and definitions where possible from other regulations, such as the DPH licensure reg, as well as the Board of Registration and Nurses regulation. We only developed new or different definitions as necessary to accomplish the purposes of the statute. So for example, the definition of acuity tool is a new definition. Here we define acuity tool as a decision support tool using a method for assessing patient stability for the ICU patient according to a defined set of indicators and used in the determination of a patient assignment. So this definition is the tool specifically called for by the law. And the regulation, as we will get into, lays out the process for the development of the tool and sets out required elements. Intensive care unit, we define ICU as required by statute. The statute says the term intensive care unit shall have the same meanings as defined in DPH Regulation 105 CMR 130.020 and shall include ICUs within Commonwealth operated hospitals. So the proposed definition included in the regulation you have before you therefore includes all intensive care units licensed by DPH as ICUs, including coronary care units, burn units, pediatric intensive care units, and neonatal intensive care units. However, they're named by the hospital. For example, we know that some hospitals specifically identify ICUs that are specialty ICUs as surgical ICUs or neuro ICUs. So however they're named, if they're licensed as an ICU by DPH, they're encompassed within this definition. And this definition would include the ICU beds at the Shattuck Hospital, which is run by DPH. The term patient assignment we define to mean the assignment of an ICU nurse made under the process required by this regulation to either one or two patients, consistent with the nurse's education, experience, and competence, and the needs of the ICU patient. Turning to the next slide, we see section 8.04, which addresses patient assignment. The regulations provide that the patient assignment for each ICU nurse, referred to as the staff nurse in the definition, in the regulation, shall be one or two ICU patients at all times during a shift. This reflects the maximum number of patients that can be assigned to a nurse as provided in the statute. We also make clear in the regulation that there's no prohibition on the assignment of more than one nurse to a patient if the patient needs require it. Assessment of patient stability. The proposed regulation provides that patient assignment for each ICU nurse, back to the assessment of patient stability. The staff nurse shall assess the stability of the ICU patient utilizing the acuity tool developed or selected pursuant to the regulations and the nurse's own assessment and judgment based on the nurse's training and experience. The staff nurse, if the staff nurse determines that the ICU patient requires a different nurse-to-patient ratio than the ratio indicated in the acuity tool, the nurse manager or the nurse manager shall resolve that disagreement between the acuity tool and the staff nurse's assessment. In that case, the nurse manager shall determine the appropriate patient assignment by consulting with other staff nurses on the unit and taking into account such factors as nursing skill mix, patient mix, and environmental factors specific to that unit to determine the patient assignment. We've heard many different perspectives on when and how the acuity tool should be used to assess patient stability. And in balancing these considerations, the regulations require, at a minimum, the administration of the acuity tool to assess the patient upon his or her admission or transfer into the ICU, and at least once per the staff nurse shift, and at intervals and circumstances as specified in the hospital's implementation policy, which is required to be established pursuant to the regulation. To provide more direction on the acuity tool itself, the proposed regulation includes two sections. 8.06 details the process of selection and development of the acuity tool, and 8.07 outlines the required elements of the tool. So turning to slide 17, the process requirements. First, the hospital must form an advisory committee to make recommendations on the tool. The advisory committee must comprise 50% RNs who are not nurse managers, and a majority of those nurses must be ICU nurses. In addition, the hospital may include other members on the advisory committee, including nursing management, other ancillary or medical staff, or others. The advisory committee is charged with making recommendation on the elements of the acuity tool, including what indicators should be included, how the scores should be assigned to each indicator, how the score should be tabulated, and then used in the determination of a patient assignment. Those indicators include clinical indicators of patient stability. We'll describe those in more detail later, but those are indicators of physiological status and therapeutic supports, as well as other indicators of nurse workload. And again, those will be described more in a moment, but those factors would be such things as patient age and communication ability that impact the amount of time that a nurse needs to care for a particular patient.
Lois, can I ask you a question? On slide 16 in our packet, the formation of the advisory committee, what's written is a little bit different from what you said out loud. 50% registered nurses, a majority of whom ours written slide says staff nurses, you said ICU nurses.
Right. So we define the term staff nurses to mean those nurses who are working in the ICU.
Yes. Okay. Great. Thank you.
So with respect to the, back on slide 17, with respect to the indicators and scores, the advisory committee must consider critical environmental factors particular to that ICU, including the physical environment of the unit, the skill mix, the availability of patient care equipment and technology, as well as availability of ancillary and support staff in the ICU. All factors which may bear on what indicators should be selected, how they should be assessed and weighted. Additionally, the process must include an opportunity for staff nurses and nurse managers to test, validate, and make recommended revisions to the tool prior to implementation, a process for the hospital to address the recommendations of the advisory committee, and following implementation, a process for periodic review and evaluation of the tool. To provide further guidance to hospitals and the advisory committee, section 807 lays out certain minimum requirements of the tool. So you see on slide 19, the tool must be in writing. It can be in paper or electronic format. It must be tailored to the unique care needs and circumstances of the patient population of each ICU. We heard significant testimony about the differences in ICUs, both across hospitals and even within hospitals. The tool must be specifically tailored to those particular patients. The tool must have some method of scoring clinical indicators and other indicators of nursing workload. And to provide more detail on those indicators, on slide 20, the indicators of patient stability These are indicators related to the physiological status and clinical complexity of the patient, the related scheduled procedures, medications, and therapeutic supports appropriate to that ICU population in the ICU in which the acuity tool will be deployed in a variety of clinical domains. You see the exemplar domains listed here. They're not meant to be exhaustive, but rather are exemplary of the types of clinical areas that the tool could assess. On the following slide, the workload indicators. Likewise, these workload indicators listed in the regulation are not exclusive. These are indicators of staff nurse workload associated with caring for the ICU patient, again, appropriate to that particular ICU population in the ICU in which the acuity tool will be used. And they include factors such as patient age, gestational age, cognitive or functional ability, patient and family communication skills, additional needs to care for and support the patient or the family, whether needed care coordination or transitional care, discharge planning out of the unit. Recall that in the process requirements in 8.06, the hospital must consider recommendations by the advisory committee on each of these types of indicators and on what is best suited to the particular ICU and how each of these indicators should be weighed or scored. Another requirement of the tool is that the hospital must develop written policies and procedures specifying how the resulting acuity tool score will be used to support the determination of a patient assignment of either 1-to-1 or 1-to-2. In terms of records of compliance, we require hospitals to keep records on both the process and results. So each acute hospital is required to document and retain for a minimum period of 10 years records related to the process it followed in the development or selection of the tool, including documentation of the required process, who was on the advisory committee and so forth, and the rationale for including or excluding certain indicators as recommended by the committee. In addition, they must keep records of staffing compliance indicating the results of the assessment of the ICU patient stability and determination of a patient assignment for each patient. The regulation does not require that these records be kept as part of the patient record, but nonetheless, we require retention of these records by the hospital. As mentioned earlier, DPH has a role in certification of the acuity tool selected by the hospital. We require that hospitals submit the acuity tool for each ICU to DPH for certification prior to its implementation and periodically as determined by the Department of Public Health. In that certification process, DPH should determine whether the acuity tool was developed or selected by the hospital in accordance with the procedures and requirements of this regulation. And of course, hospitals must comply with the procedures for certification and enforcement as established by DPH. As for required reporting, in developing the reporting requirements, we again tried to strike an appropriate balance here, recognizing that reporting is important both to promote transparency as well as to promote compliance. But also we were worried of imposing undue administrative burdens. So with that, the regulation requires that hospitals must report at least quarterly to the Department of Public Health on the staff nurse-to-patient ratios by ICU and to identify any instance in which the minimum staff nurse-to-patient ratio of 1-to-2 was not maintained and the reason for that. Hospitals must also issue quarterly reports to the public on staff nurse-to-patient ratios by ICU on their website and as may be specified by the Health Policy Commission in guidance. We had a lot of testimony and input on quality measures, and as indicated earlier, the Health Policy Commission is required to identify 3 to 5 of ICU-related quality measures to be measured and reported by hospitals to the public. Following our December 10th meeting, we actually asked for additional comments and feedback on quality measures, and we recently received some detailed, very helpful input from a number of parties. and we are continuing to review that material. So you will see that the proposed regulation today does not specify those measures. We expect to finalize those measures either through sub-regulatory guidance or in the final regulation, and we'll continue to process those through a public process. So you'll see on the next slide the list of measures that we have received comment on, and it's not an unlimited universe. There are some consensus on particular measures, and as always, we are trying to evaluate and assess these measures based on a number of principles, including that the measures be evidence-based, validated, nationally accepted, we're capable of benchmarking these measures and performance over time, that they're currently collected and reported in Massachusetts. To the greatest extent possible, we're focusing on measures that are nursing sensitive and, if possible, applicable across ICU types. So as you will see in the text of the regulation, we require that once the measures are specified, they must be reported to DPH and made public on the hospital's website annually. In order to promote planning for adequate staff needed to comply with the law, the regulation also includes a requirement that hospitals develop and implement a registered nurse staffing plan for the ICU in which the acuity tool is deployed. And that plan should incorporate data gathered from the implementation of the acuity tool. In terms of an implementation timeline, the proposed regulation provides that a hospital shall submit an acuity tool for each ICU to DPH for certification no later than October 1, 2015. We recognize that the Department of Public Health will need time to review and then process certifications, so our timeline is pegged on the time that the hospital should begin that process of certification with DPH. I'll pause there for discussion, and then we can talk about the regulatory next steps.
Just as a point of clarification, DPH still has the ability to decide whether these tools have to be certified annually. If I kind of flip back to
Yes.
that, is that correct?
That's correct.
So it could be annually, it could be less frequently.
Yes.
Thank you.
Thank you, Lois. So let me open it up for questions and other comments by the committee. Dr. Ella?
Maybe you can hear me now. Thank you. First of all, I want to comment on what a thorough and great job you've done trying to take what was in the statute and come up with something that's an actually usable process. So I thank you and congratulations on that. A couple of things struck me as reading it, and I'm going to do some specifics. I guess the one overriding thing I'm worried about is that somehow the documentation overloads the system and becomes the main thing. And somehow we have to avoid that it's not all about documentation. There has to be documentation, don't get me wrong, but it can't take the place of patient care or add to the nurse's burden of what they're already doing or add to the hospital's burden of more paperwork or more things to keep track of. So that's just a gut reaction to especially some of the stuff near the end of it, and maybe I'm not understanding some of the language around keeping records around each incident or each patient. So that's a general comment. The other thing is, even though I know on slide 20, let me go back to that you said that the list of conditions or systems was not exclusionary, or that it was just exemplary, I think is what you said. There were still some major systems that are left off the list, and I would request that they may be added on, so that I would think would impact on patients in the ICUs. For example, hematologic is one of them. renal might be one, metabolic, and then infectious is another. Those seem to me to be things that would land patients in ICUs and are actually becoming predominant if you think about things like Ebola and influenza and some of the other the things that affect children certainly are in those categories. There's also psychiatric, and I don't know where that fits in exactly. I know that the next slide sort of deals with that, but I think that is your brain is part of your body, and it is a system also that may be looked at. But anyway, so that's just a specific comment. And then finally, my other general question, I don't know what slide we're on, but in the advisory committees, I would encourage hospitals to include some kind of patient or family representative. Not somebody who's in the ICU necessarily, but assuming that the hospital has either a patient advisory committee or some mechanism to include patients and family in their quality improvement areas, to include those people. I was recently at the PCC conference in Washington, and some of the most informed and passionate advocates for change and for making things better were former patients or parents who do sit on those committees and have talked about their own experiences having been through ICUs, and we can certainly benefit from that. So that would be, I would just encourage, I don't know if you have to embed this that in your red, but I just would encourage hospitals to include that kind of representation. So I think those are my comments. Thanks.
So I don't know if that'll reach. Can folks hear me in the back? So on the so everybody's required to have a PFAC. So I think the recommendation is good. I would submit. I don't know if I would codify it in the regs as opposed to the guidance that comes out either from the department or from the HPC.
Yeah.
Frankly, PFACs are at various levels across the Commonwealth, so I think it makes perfect sense if the, first off, all hospitals should be moving to have more robust patient-family advisory committees in any event, but maybe through the recommendation to do that makes a lot of sense. I had a couple quick questions. I'm on slide 25, where we're talking about the reporting to the department, and I confirmed that the bullet A there, we're talking about staff to patient ratios by ICU in the aggregate for the respective ICUs. I think one of the things that would be important for the committee, the HPC, and ultimately DPH to understand is that those numbers should not be used ultimately as the bellwether of whether or not quality is actually happening based on, in the aggregate, my staffing is 1.2 to 1 over that quarterly period, or it's 1.7 to 1, or it's 2 to 1. I think the other outcome indicators are really going to be the important metric. That indicator is just to show, I think, it should be that people are in fact compliance with the regulation, not that it's an indicator of quality and or outcomes for the respective hospitals. We all know there's significant variance in the risk profiles of patients in ICUs across the Commonwealth. So I would just ask that people take that into consideration as they do that. On slide 27, where there is the conversation of the collection and reporting of proposed quality measures, which I think is a good list. A lot of these on this list are serious reportable events, and so are therefore already reported to either the Department of Public Health or through the QPSD at the Board of Registration in Medicine. I would just want to, I think, ensure that we're not double reporting things that are required to already be reported. If there's a way to on our side, on the the government side to take into account a report that went to the Board of Registration of Medicine or went to the Department of Public Health and collate that. I think that makes sense, but let's not make the folks report it to QPSD and then to the Department of Public Health and then separately again as a part of this overall, the overall metric. But I think the metrics, you know, in and of themselves are.
So Secretary Polonowitz, would you suggest then that if those items are already reported, that then this list should be metrics over and above?
So,
I mean,
yeah, so I would say we should not duplicate them.
Right.
I think when you pull out the ones that are already currently reported, it becomes a shorter list, and then the question is, you know, what is the one source of truth that we're going to have, or what's going on from a quality and an outcome perspective in our ICUs across the Commonwealth? I think we should think about, and maybe in context of you sitting down with Commissioner Burrell, Director Commissioner Burrell, when she gets here, about how that reporting should really happen. We've begun some of that process with the Department of Public Health. We've still got a lot of work to do to not only overburden the system, as you indicated, but the reports that we're getting to have the relevant information that we can actually do something with, and not just have it reporting for reporting's sake.
Dr.
Sorry, just when we're talking about quality measures, two things. One is there aren't a lot that are relevant to NICUs or pediatrics, so you might want to look a little more for that. And then I would strongly encourage including some kind of patient experience or family experience measure as a quality measure.
Well, can you clarify the 10 years? Is that a general reporting to the Department of Public Health requirement?
That's a retention requirement.
Perhaps I should know the answer to this, but I don't yet. I missed it in my orientation.
That was on page 870 of the orientation document that I sent you.
I fell asleep at 8:65.
That's just that each hospital, so the documentation of the process and the actual sort of results of the acuity tool and the actual patient assignment retention of those records, similar to a retention of medical records, which is 20 years. And this, recommendation of 10 was actually staff at DPH did recommend a period of time long enough to span different surveys when they go out to do hospital surveys, so they didn't want to sort of miss records if it was only 5 years. They thought that was too short. So we kind of benchmarked it to between the medical records and sort of 5 years. So.
Other comment?
I had one other comment. Back on slide 18, the sub-bullet F, where it talks about the periodic review and evaluation. Given the timing of what we have in the regulations in terms of getting the acuity tool to the Department of Public Health by is it October of this year, I think we want to make sure that we're giving organizations flexible. There's going to be a number of organizations that are going to have a stubby pencil approach to this with paper and pencil. Even if they want to move towards an electronic system, as ideally most hospitals would have this as a part of their ICU documentation system, as a part of their electronic medical record. The time that we have to do that isn't probably going to allow that unless they've already begun that process. So we just want to make sure that that we do have the ability for them to make those changes, because I can envision, in order to comply with regulations, we want to have an interim approach based on the committee that's pulled together of how to measure this, and then subsequently an implementation. So on both sides, giving them the flexibility and ensuring that the department has the ability to go out and do their follow-on assessments as they move from one measurement tool to another, I think would be important.
just to add on to that, and maybe, Lois, this comes in the guidance and not in the regulations. If we only have roughly 20% of the hospitals using an acuity tool now, then that really even reinforces Counsel. I think the other question in the guidance that we may want to address is if a hospital is on the other end of the spectrum and has a fully implemented, integrated electronic health record, particularly for the ICU, then can we allow what resides within the patient record to be considered a measure that would meet this documentation requirement? Because there's the 20% of numbers of hospitals, and then there are the academic medical centers that actually have a larger percentage of beds, where they may already have this embedded in the patient record. And going to Carol's point, we don't want the hospital and the nurses to have to be filling out a whole separate form if those data are already collected. So it's a little bit of a Gordian knot, but if we could just address this as a problem that needs to be solved when you write your guidance, that would be helpful.
So I just want to understand what you're talking. So in an academic medical center has an ICU documentation system. You're saying to be able to use some of the clinical indicators out of that system in order to drive the acuity, because they may not have an acuity tool built in.
But they may.
Yeah. Okay.
So I'm only saying if they do, and to some degree, I think of California as a little bit ahead of us in this game. You know, they have, some of those hospitals have acuity tools built into the electronic health record where you measure the patient's status on a shift, per shift
Apache
basis.
scores, for instance.
Exactly,
Right.
Apache scores, exactly right. And those are kind of nested within the record. So we don't, you know, is there a way to use those per shift scores as an equivalent measure to meet this reporting requirement, rather than having someone have to do it separately and all over again with your study pencil?
Right. No, it would seem to me in that instance that if the advisory committee that the hospital had put together, upon their review, said, the Apache score plus X or Y really allows us to do the right kind of acuity measuring, then yeah, I think that would make sense.
I think that's right. I think
Yeah, we don't. This should not be. Ultimately, this should be a part of the care process, not a bolt on to the care process. So.
that's right, and I think Mr. Secretary is correct that it's a question of process. So having the committee sort of review what's already in place, and to the extent that it needs to be tweaked or adapted or provide more input provided, as long as that goes through the process and meets these requirements, it can be certified. Other comments? Do you want to go through the process? So, looking at next steps, we have an aggressive year ahead. Assuming the committee votes today to advance the proposed regulation to be considered by the board would do that at the January 20 meeting to discuss the proposed regulation and vote to issue the regulation as a proposed regulation for a notice and comment period. In February, we would hope to convene a working group to discuss evaluation of the law. We have always had the plan that we would want to design a study to measure the effect of the law's implementation and its impact. So we want to get started on a working group to design that process. We also expect in February, as I mentioned, to release recommended quality measures after further deliberation based on our recent input. And we put those out again for public comment. We would expect in March to have a public hearing under the auspices of the committee and initiate our public comment period. We would have further discussion of our working group and evaluation plans. In April, we would come back to the committee for discussion of a proposed final regulation and vote to advance that hopefully to the full board. We would plan then for the April 29th board meeting to have a discussion of the final regulation and vote to approve and authorize it. We do expect that sometime thereafter, DPH would develop and promulgate any regulations it would need to do for certification and any enforcement processes.
So Madam Chair, just to emphasize one process point here, today marks another step in what has been and will continue to be a robust public process to address these regulations. I think we have worked with many of the people in this room in multiple meetings and will continue to be able to do so. Where there is no model for these regulations, we really do think that advancing a draft regulation will help this conversation move forward in a very constructive way, and that there will be a lot of benefit that can come from having some draft regulations out in the world that we can sit down with, excuse me, and really be able to discuss the implications of and the definitions and some of the very specific nuances. So would expect, a continued robust public process here and the potential for some changes even as we get to that final regulation. Different, even more so than in other regulatory processes the Commission has undertaken where there has been more of a model to work off of. And would say, the legislature gave us this responsibility, and it's a complex responsibility with labor and management and patient safety issues. I think one of the reasons that they did was our work on mandatory nurse overtime. And there, it wasn't necessarily that the end product was something that everyone agreed with, but that we conducted an open and transparent process in coming up with that end product. And so a commitment to everyone in the room that we'll continue to be open and willing to meet with anyone to discuss these regulations and changes as we move this process forward.
I just want to add, I think a lot of the credit for that whole process being so open on everything goes to our chair, Commissioner Sutter. So I just want to acknowledge her process and the work that she's done. She moves forward to a different role.
So, in reviewing, Lois, the next steps, I think it's really going to be critical to get the draft regs out there because we will have consumed 4 months of the year in getting to a final regulatory framework, which leaves the hospitals with their advisory committees 5 months to kind of pull together and, for 80% of the hospitals, kind of an entirely new approach to doing this. So it would seem to me that getting the draft regs out, that there's a lot of groundwork that the hospitals with their staff can start on now in terms of, well, what are we collecting, where are we at, vis-a-vis anything electronically, in all likelihood, even with the public comment. If there's not a lot of changes, the work that goes on won't have been wasted in terms of just setting the backdrop. How are we going to measure this? Is it going to be different in terms of clinical indicators for the different ICUs in bringing that process together? I would just caution that the organizations, while we're waiting for the implementation, the final certification by DPH, work probably needs to happen, after, as soon as the HPC, if the HPC allows us to go to public comment, that work should probably start now and not waste the 4 months of time.
So before I put this to a vote, can you just clarify a little bit around March? So we're going to have a good process around the outcome measures. And do we expect them to then be amended into the draft regs that will go out for public comment into one regulation, one proposed regulation?
I think we haven't fully decided, which is the appropriate. Certainly, if, it may be more appropriate to have them in HPC guidance so they can be sort of changed and modified over time as quality measures are developed and changed, we could do that. But we certainly, in doing it this way, we're not trying to sort of not do it in a public process. We expect the process of public consideration to be in tandem. And whether the committee and or commission decides it's more appropriate to include them in the regulation or guidance, we sort of leave that up to the process.
Yeah, and it would seem to me on that, that's a perfect opportunity for, how we do with the department, with either circular letters or sub-regulatory guidance. I think ideally what we would have as a part of the regulations is the broad construct to ensure that we're in compliance with the goals of the statute. And then, because there are going to ultimately be changes, as you indicated, we'll pull together a committee to really look at the effectiveness and implementation of this. There may be, there will be other people sitting here in a year saying, geez, we really need to think about this in a different way, and being able to do that through sub-regulatory guidance, I think makes a lot of sense.
So we have a specific motion. I had it at 32. Thank you. So I'd like to call the motion that the Quality Improvement and Patient Protection Committee hereby approves the advancement of the proposed regulation on registered nurse-to-patient ratio in intensive care units and acute hospitals to the full board for vote to issue and solicit public comment. So again, this is not final regulations at all. It's to put it forth to the board to approve for public comment. Does we have a second? Any further comment?
That would include some of the discussion of changes that we made today or not? I'm just curious, like if we added heme in that section.
The other indicators.
The other
These
indicators.
things would be included as what, in what we.
Yes, and as you,
Yeah.
we made a few
Changes.
changes already, and
Okay,
we
so
can-
that, yes. So I'm sorry, did you second?
I think we have a second,
Zero.
and you clarified. So the changes you made, particularly on those indicators, would be added.
Okay.
All in favor?
Aye.
Okay. So I'd like to note that these regulations, these draft regulations will be posted online in 1 hour after the end of today's meeting.
No pressure.
Thank you. No pressure. That was a note I was asked to read, so it's public. All right. So, do you have any further business? Yeah. So I'd like to, since we are done with our meeting, we'd like to open this up for comments. Anybody would like to issue public comments? And please just identify yourself.
I'm Carson in Massachusetts, and I really just want to applaud the work of the committee for recognizing the diversity of hospitals across the Commonwealth and really bringing the voice of the staff nurse forward in this process. So thank you.
Thank you. Anyone else like to offer comments at this point? There will be plenty of time for more comments, of course. All right. Well, with that, I'll call the meeting to end. Thank you very much. And I just want to, again, acknowledge Secretary Polano and all the work he's done for Health Policy Commission in the Commonwealth. Thank you, John.